Hi, everyone. We're going to get started in just a minute with the webinar. We're going to give everyone a little bit more time to log on, and then we'll begin. All right, well, hi, everyone. Welcome to the webinar, Ovarian Cancer 101. I'm Maggie Nicholas Alexander, and I'm the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org. Now for some housekeeping for the webinar. All participants will be muted during the presentation. When Dr. Werner finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. When asking questions, remember that Dr. Werner is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce today's speaker. Dr. Theresa Werner is an associate professor in medicine in the Division of Medical Oncology at the University of Utah and a clinical investigator at the Huntsman Cancer Institute. Dr. Werner is the medical director of the Clinical Trials Office and is the recipient of the 2016 National Cancer Institute's Cancer Clinical Investigator Team Leadership Award. Dr. Werner specializes in women's cancers and serves as the PI for numerous clinical trials in gynecologic and breast cancer. She writes investigator-initiated trials with a focus on genomic biomarkers aimed at predicting responses to targeted therapy in cancer patients. She has developed a practical training course for PIs in clinical research for the University of Utah. And we're so excited to have her join us here today. So Dr. Werner, thank you for being here, and I'll turn it over to you now.
Thank you, Maggie. All right, everybody can see my screen, I hope. I just want to thank the SHARE team for inviting me, and I want to welcome all of you to our webinar today. This is Ovarian Cancer 101, and it's really geared toward patients. So as Maggie said, I'm a medical oncologist, and I specifically just work with women's cancer patients, predominantly gynecologic cancer patients. And I would say a lot of my practice is ovarian cancer patients. And I've geared this talk. It's very similar for when I meet a new patient in clinic and they're coming to me for the first time and don't really know anything about their cancer other than the fact that they have ovarian cancer. And so the structure of this talk today is kind of what I do with every new patient to kind of explain things to them. And we're going to talk about all different kinds of things with ovarian cancer, and then finish up with some treatment discussions about some of the newer treatments that we're doing in ovarian cancer. And as Maggie said, please feel free to write your questions in the Q&A section, and I will do my best when we're finished to get to as many of those as I can. All right. So today we're going to talk about incidence and survival rates of ovarian cancer. And I have some basic slides to talk about the types and specifically the histology of ovarian cancer. We're going to talk about staging and grading and what the difference between those two are, and then briefly touch on surgical treatment, and then finish up with some medical treatment. All right. So this slide shows the stage at initial diagnosis when someone gets diagnosed with ovarian cancer. So you can see here that there's no effective screening for ovary cancer, which is why, unfortunately, the majority of patients get diagnosed with disease that's already spread. 1.3% of women in the United States will be diagnosed with ovarian cancer at some point during their lifetime. So you can see here, patients present with localized disease about 16% of the time, regional involvement, which could include lymph node involvement 21% of the time, and the majority will present with distant disease. And if we look at survival rates of ovarian cancer, it directly correlates to the stage or how early your disease is caught. So if you have localized disease, your chance of surviving is very high. And then you can see the more spread your cancer is at diagnosis, it falls off from the localized disease to regional. And then unfortunately, we don't have great survival rates with distant disease historically. I want to just briefly touch on this because the rest of the focus of this talk is namely on epithelial ovarian cancer. But when we talk about the ovary, there's really three main types. And so just in case anybody on the phone has one of the other types, I wanted to briefly mention this. So this is a picture of the ovary. And what we're going to talk about mostly are the cancers that start in this epithelial layer, which is the outside lining of the ovary. But the two other types that we see are something called germ cell tumors. So this is a depiction of the germ cell. This would be the female equivalent of testicular cancer, for example. And then there are the cells, the support cells that support the germ cells. And those types of tumors are called sex cord stromal. And again, you can see they're not very common. So 5% germ cell, 5% sex cord stromal. The majority of ovarian cancers that we see in practice are the ones that start in this epithelial layer. So that's going to be the focus of the rest of this talk. And when we talk about epithelial ovarian cancer, it's also abbreviated EOC. You may see that abbreviation. These are the main histology types that we talk about. So the majority of what we see is something called high-grade serous. You can see 75%. And then less commonly endometrioid, clear cell, mucinous, and something that's called low-grade serous. And I know this slide looks a little bit busy, but I do want to just briefly touch on this concept because as a patient, you may hear lots of different things like this is the stage of your cancer, this is the grade of your cancer, you have a type 2 tumor, and it gets a little bit confusing. So I want to do my best to try to explain this to you. When we think about epithelial ovarian cancers, we really group them into these two main groups. What we call type 1 tumors, which you guys can see are depicted at the top in the blue. So these 4 blue squares, for example, and then type 2 tumors, which are depicted in the bottom in the red. So these are pathology slides of what these tumors look like under the microscope when the pathologist looks at them for us. So some of these names you heard me talk about serous, you heard me talk about endometrioid on the previous slide. So these tumors tend to be very slow growing. And they evolve through a stepwise process. So a lot of these tumors will start as borderline tumors and then turn into invasive cancers. As opposed to these tumors down the red, you can actually see the difference if let's compare the endometrioid one at the top and the endometrioid at the bottom. This one definitely looks more erratic and disorganized compared to the top. So these are also what we call high-grade tumors. They tend to evolve rapidly and tend to be more aggressive in nature, and they don't follow that stepwise progression like the type 1 tumors at the top. So this will be important because the majority of cancers tend to be these type 2 tumors in the epithelial ovarian cancer realm. This slide is just wanted to talk to you guys about what grading means. You heard me talk about just on that previous slide, low grade versus high grade, for example. And that gets a little bit confusing to people as well because we also grade them by numbers, okay? So grade 1 tumors are also known as low grade or well differentiated. So this really means that the cells look like and they're organized like normal cells, for example, and these tumors tend to grow very slowly. As opposed to grade 3 tumors, I'm going down to the bottom here, which also are known as high grade or poorly differentiated tumors. These cells look very abnormal and they don't really resemble any normal tissue structure. They tend to grow very fast and can spread rapidly. And then there's also grade 2, also known as intermediate grade, or what we call moderately differentiated. So it shares features between the grade 1s and the grade 3s. It's sort of an in-between. But in the ovarian cancer world, we don't usually have a lot of grade 2 tumors. They tend to either be grade 1 or low grade, or they tend to be high grade or grade 3. Okay, so when you hear something about grade of your tumor, this is really what it's talking about. What does it look like under the microscope? Does it behave more like normal cells, or does it behave very abnormally and grow fast? Okay. I want to focus on how ovarian cancer can spread, because a lot of patients come to me thinking, you know, I didn't feel sick at all and I got diagnosed with stage 3 ovarian cancer. How does that happen? And a lot of that has to do with how these cancers spread. So they can spread locally. So the cancer cells or the malignant cells are shed, or they come off of the ovarian surface or the fallopian tube surface, for example, and they can spread to any other area that's in the abdomen or pelvis just by floating around and attaching to other structures. These tumor cells can also spread through the lymph node system. And so this is known as lymphatic spread. And oftentimes we will see pelvic or other intra-abdominal lymph nodes that can be involved in ovarian cancer. And then the third way cancer cells can spread is through the blood system. And this is also called hematogenous spread. This is less common in ovarian, but it does happen. And those tumor cells, if they get into the blood vessels, can go to other places. So in ovarian cancer, namely the liver and the lung are the most common places we will see the cancer spread, sometimes the brain. And so if any of you have been diagnosed with ovarian cancer, you may have had surgery as part of your care. It's a keystone in the treatment of ovarian cancer. And so this surgery is generally an exploratory surgery. And what the surgeon is trying to do is assess the spread of the cancer. And their goal is to remove all visible disease. So anything that looks like cancer at the time of the surgery, they want to remove it. This is also known as a debulking surgery. So you may have heard that term. So what they're trying to do is remove the bulk or debulk the tumor. And in this cartoon picture, you can see the intra-abdominal organs. And as part of that surgery, the uterus, the fallopian tubes, and the ovary are removed. The surgeon can also remove any lymph nodes that look like there's cancer. There's also, this is depicted sort of here in yellow. Hopefully you guys can see this. It's known as the omentum. It's a layer or an apron of fat that overlays the bowels, and ovarian cancer tends to go there a lot from that local spread that we just talked about. The surgeon will also look at the liver and they will examine up underneath the top. So here's the top part of the liver, and your diaphragm or your breathing muscles sit right on top of the liver and the spleen, and they will examine those surfaces as well. One other thing that the surgeon will do is they will do what we call pelvic or peritoneal washings. They'll put fluid right inside the abdomen, and then they'll remove it, and we'll see if there are any cancer cells as well. So these surgeries tend to be very extensive and can take several hours. But again, the goal is to remove all of those cancer cells that they could see. This leads us now to staging. Okay, we've talked about, in the one slide, we talked about type 1 versus type 2 tumors. And then the next slide, I talked about grade of tumors. And really sort of the final concept is what we call stage. Okay, so stage really tells us how spread or how advanced is this cancer at the time of your diagnosis. And most people get diagnosed at surgery. Okay, so in the ovarian cancer world, we use the staging called FIGO staging, and that's the International Federation of Gynecology and Obstetrics. So you may hear that. And this slide is really basic, and it's an easy way to remember the staging of ovarian cancer. So stage 1 is if the tumor is limited to one or both ovaries. Stage 2 is if the tumor has then spread to anywhere else in the pelvis. And when I talk about the pelvis, it's really the lower part of what you think about as your abdomen. So kind of behind your bladder and below. And then stage 3 tumors can have metastasis outside the pelvis. So anywhere in the upper abdomen, for example. And then when we talk about stage 4, that would generally mean distant metastasis. So you've got disease, either in the liver or the lungs, for example. So that's a really easy way to remember the staging. This next slide, I know it is very, very busy, and it's really just for reference sake when you guys look at the recording or you get the handouts. And we updated the staging in 2013, and the changes are in blue that you can see there. And so many of you may have heard, oh, I have stage 3B disease, and wonder, what does that letter mean? And so in the oncology world, we like to be very specific. So when we talk to each other, if I say this patient has 1C disease, I immediately know what they're talking about, the extent of the disease. So you can see each of the stages have several sort of sub-stages underneath it, which are really descriptive. And so again, if you just remember the prior slide, stage 1, ovaries, stage 2, pelvis, stage 3, outside the pelvis, and stage 4, distant, that's an easy way to remember it. I have a few slides, and I just want to talk about hereditary ovarian cancer for a minute. Because there's a lot of data and a lot of talk about BRCA mutations and having your genetics done or your tumor genomics done, and it gets very confusing for patients. This also will tie into some of the new treatment options that we have in ovarian cancer. So I just want to have a little bit of background for you guys when we get to those sections. So at least 15% of all cases of ovarian cancer are associated with what we call hereditary factors. Many of you may have heard of BRCA1 or BRCA2, for example. 70% of these inherited cancers have what we call a BRCA1 mutation, 20% have a BRCA2, and the rest have other syndromes, family cancer syndrome known as Lynch syndrome, for example. And the reason that that's important to know is because the lifetime risk of someone who has one of these germline or genetic mutations is much higher than the general population. And so, for example, if you had a family member who had a BRCA1 mutation, their lifetime risk of ovarian cancer goes from that 1.3% that we talked about earlier to up to 30 to 40% over their lifetime. So it's a much higher risk disease in that patient population. And if we know that, that will cause us to make some different treatment recommendations for that patient and their family regarding other things that we can do to prevent ovarian cancer. And I do want to just take a minute and walk you guys through this slide just for terminology's sake, because I find that the more that we talk about this, and if I can show it in this way, the patients will understand it better, because I know some of my patients get confused about it. So I thought this would be a good slide to show you. I want to start on the right-hand side. And this is what we call genetic or germline mutations. So these mutations or alterations in the DNA are present in the egg or the sperm, and they can be inherited from parent to child. And these mutations generally cause a family cancer syndrome, for example. So if the parent passes that mutation, which is dictated by this yellow star, onto the child, all the cells affected or all the cells in that offspring will have that mutation, for example. Okay, so we talked about BRCA1 mutation on the prior slide. So again, if a parent had a BRCA1 mutation, they have a possibility or a chance of passing that on to their child. That's what we call a genetic or a germline mutation, meaning it's present in all of the cells. So that's in contrast to what's depicted here on the left-hand side. So these are not germline mutations. These are what we call somatic mutations. And so these mutations are in the tumor. So it's not in all of the cells in the body, and it's only in the tumor cells. And these are not passed on to offspring, so they can't be inherited. So later on, when we talk about germline versus somatic mutations, that's the difference. So the germline ones are in all of the cells and can be passed on. The somatic ones or somatic mutations are just in the tumors. And so if there are any questions about this later, I'll be happy to go over it again. But again, want to give you guys a background because I find that that's a common thing that gets, that's a little bit confusing to patients sometimes. And this slide, again, I don't, expect you to know any of the details. Really, the point of this slide is that there are many different genes. You can see BRCA1 and BRCA2 that we talked about, but there's actually a whole family of genes that make proteins that help us repair the DNA. Okay, so if all these genes are working properly, your DNA gets repaired. And it's what we call genomic stable. But if your DNA has any mistakes in this group of genes, for example, it's thought to be genomically unstable. Okay, so really it's looking at a family of proteins, genes that make proteins that help us repair the DNA. And this is going to come into play later when we talk about some of the newer therapies for ovarian cancer. And when we talk about DNA repair, this term comes up a lot, homologous recombination. So it's a way to repair the DNA. So it's either intact and it's working properly, or it's dysfunctional, for example. And we'll hit on this again later, but this is a good background slide. I now want to shift to treatment, and we're really going to focus on the treatment of advanced disease. We've already talked about the surgical staging procedure. And again, your gynec surgeon is going to make every attempt at taking out all of the visible disease that they can see. Okay, so you will hear terms like optimal debulking. And what that means is that the surgeon was able to remove all of the disease, and the only thing that could be left is less than 1 cubic centimeter of cancer, for example. There are some cases where, let's say the cancer is too close to an important blood vessel and they can't remove it all. That would be known as a suboptimal debulking surgery, for example. So you may have heard those terms. So after surgery, we generally recommend chemotherapy, and this is known as adjuvant chemotherapy. So the most common question that I get from patients when they come to see me after surgery is, well, if the surgeon took out all the disease, then why do I have to have chemotherapy? Well, we worry that there might be microscopic cells, microscopic cancer cells left behind, and we can't see those with a scan. The surgeon can't see them with their eyes. And so we worry that if we don't do any further therapy, if there are any cells left, those could continue to grow and then cause a recurrence of the cancer. So really the goal of chemotherapy is to eradicate or get rid of any microscopic residual cancer cells. And generally for ovarian cancer, there are 2 main chemotherapy drugs that we use, a medicine called paclitaxel and another medicine called carboplatin. These are both generally given intravenously or through an IV to get into the bloodstream. And we will do 1 treatment every 21 days, or it's a 3-week cycle. And depending on the stage of disease and particulars about your disease, most patients with advanced disease get 6 cycles of chemotherapy. Some patients with earlier stage disease may only get 3 cycles, but that's generally the schedule for the chemotherapy. I briefly just want to mention there are a group of women with ovarian cancer that can't go to surgery in the very beginning. Okay, we've talked about surgery followed by chemotherapy, but there is a subgroup of patients who, for whatever reason, can't have surgery initially. So we could say, for example, let's say someone got diagnosed with a blood clot and they just got put on blood thinners, and it's not an ideal time for them to undergo surgery. So in this subset of patients, what we end up doing is doing chemotherapy before surgery. So that's also called neoadjuvant or preoperative chemotherapy. And we use the same medicines. And generally what we do is give 3 cycles of the chemotherapy, and then hopefully the patient is able to go to surgery, and then we'll finish up the chemotherapy. When we first started doing this, over a decade ago, a lot of people were worried that maybe those women wouldn't do as well because they couldn't have surgery in the beginning. But there was a large study that was published about a decade or so ago that really showed that there was no difference in recurrence and no difference in survival if we switched the sequence and started with chemotherapy. And in fact, a lot of these patients had less complications because they had less disease at the time of their surgery. So it made surgery a little bit easier. And in fact, the surgeons have a higher rate of being able to remove all of the cancer cells. Okay. And then later on in the talk, I'm going to briefly talk about HIPEC therapy. So this is chemotherapy that's given during surgery. Especially, it's been studied in this patient population who had to start with chemotherapy. So I do want to mention that because many of you may have read about that. And then at the end of my talk, I'm going to talk about maintenance therapy. That term, where that term comes from, is once we finish the surgery and the chemotherapy, we're hopeful that our patients are in remission. And then the goal after that is to keep them in remission or maintain their remission. And so that's where the maintenance therapy comes in. So it's additional therapy that we can give after surgery and chemotherapy to help keep our patients in remission. Okay. And I like history, and I think, as Maggie had mentioned earlier, clinical trials are a passion of mine. And so I really want to pay honor to all the women before us who participated in clinical trials, because those women are how we have figured out what the best thing to do for ovarian cancer is. And so just a little bit of history, there were two important trials. 20 years ago, I think these were published. And the first trial that I show there, it really was the first trial that showed using a platinum agent and a taxane, so similar names to both of those medicines that I already talked about, that set the standard for treatment with ovarian cancer. And the second trial looked at carboplatin specifically and found that it was just as good as cisplatin, so maybe less side effects. I call it the kinder, gentler cousin of cisplatin. And so this really established the new standard of care for ovarian cancer in using those two agents. So just a little bit of history for you guys. And then I know many people are scared about chemotherapy and they want to talk about side effects of chemotherapy. So when I first meet with a patient and we talk about the chemotherapy regimen, I go through and write down a very extensive list. Many of these things are on the list that I talk to patients about with this particular chemotherapy. And so, for example, we talk about fatigue, we talk about bone marrow suppression, hair loss, neuropathy, nausea, all of these things. Just for you guys to know, though, every chemotherapy agent has its own group of side effects. And so a lot of times I'll have patients say, well, my friend who has colon cancer, didn't have neuropathy. Why is that? Right. And so every chemotherapy has its own set of side effects. So it's important when you talk to your oncologist about your chemotherapy to go through what the potential side effects are for you and how to manage those. If you think back to my very beginning slides when I talked about ladies who have higher stage cancer and the survival rates, we in the cancer world have spent lots of time thinking, well, how do we improve that? How do we improve the outcomes of these patients with ovarian cancer? So there are a lot of different things that we've looked at. So what about giving more than just those two chemotherapy drugs to patients? Does that help? What about giving higher doses or modulating the schedule? Will that help improve survival? Can we give the chemotherapy in a different way, not just in the IV, for example? Could we give it inside the abdomen or intraperitoneally? And then most recently, we've looked at adding other things to chemotherapy. So targeted therapy, and we're going to talk about that later. And then again, I'm going to go through the maintenance therapy. So if we get ladies in remission, can we maintain that remission by giving them additional therapy afterwards? So these are all the things that have been studied and continually are being studied in the ovarian cancer world. So this was a pivotal study in 2009 that was published. And really what we wanted to know was, well, if we add an additional drug or an additional chemotherapy that we know works in ovarian cancer, can we improve the survival? So here depicted is our backbone, the two drugs that we've talked about. These are three other medicines that are active in ovarian cancer. And so in this study, we looked at adding these or a combination of these. And what we found that an additional chemotherapy does not improve overall survival. So in this case, more was not better. And then we've also looked at, well, can we give the chemotherapy differently? So there is a way to administer chemotherapy known as IP, or intraperitoneal chemotherapy. So this is chemotherapy that's directly given into the abdomen, and the peritoneum is the lining of the abdomen, with the thought that the direct application of the chemotherapy to the main sites of the disease or the cancer would help. And it was being studied in patients who had advanced stage disease, so generally stage 3 disease, and the cancer was all removed at the time of surgery. And so patients would go to the operating room, have their surgery, and then the chemotherapy could be given intraperitoneally, for example. So there were 3 studies in this setting that showed improvement in survival. And so those are just a listing of the 3 different studies. After those were all completed, the National Cancer Institute issued a recommendation that in a certain population of women with ovarian cancer, intraperitoneal therapy should be considered. So on the left, GOG 172, this was the pivotal trial in that list of trials that I just showed you. And what that study looked at is doing IV chemotherapy, like what we've talked about, and then doing and comparing it to a combination of doing some of the chemotherapy IV and some of the chemotherapy intraperitoneally. And it showed that people who got the combination IV and IP chemotherapy actually did better and lived longer. The problem with that study is that 40% of the women could not finish the therapy because of the side effects. Okay, so there was maybe more kidney dysfunction, more neuropathy, more nausea. Patients had to be hospitalized because of side effects. So it's great if we have a new therapy that can improve survival, but it's not any good if we can't get the majority of patients to tolerate it, right? So more recently, the Gynecology Oncology Group, which is a national group that does trials in ovarian cancer, said, well, knowing what we knew from before, maybe we could try this trial again and look at things in a different way. So this trial compared intraperitoneal chemotherapy, a medicine called cisplatin, which is what was historically used, and we looked at doing intraperitoneal chemotherapy with carboplatin, which is one of the drugs that we've already talked about. And one of the other things, there was a targeted therapy agent known as bevacizumab, which we're going to talk about in the next coming slides, that was included in this trial as well. And so when this trial completed, we looked at all the arms, and unfortunately, there was not a benefit to the intraperitoneal therapy like we had seen in the previous trial. So this caused a lot of oncologists to really think about, who could benefit from intraperitoneal therapy and if it really should be used, in this day and age. And a lot of us have asked, why were the results so different? And there were different doses used in the more recent trial because we knew women potentially couldn't tolerate the higher doses that were used in the past. And there was a lot of thought that maybe adding some of that targeted therapy took away from some of the other benefit that we saw with intraperitoneal. So I bring this up because you may hear about intraperitoneal therapy, especially when we talk about HIPEC therapy, but this is some of the history about how intraperitoneal therapy was used and maybe why it's not used as often in ovarian cancer now. Okay, so HIPEC. So many of you have probably heard of this as well. So this is hyperthermic intraperitoneal chemotherapy. That's what it stands for. And the chemotherapy is heated and it's put directly into the abdomen at the time of surgery. So this was looked at in a study from just a few years ago in patients who had newly diagnosed ovarian cancer. Now, this was a group of women who could not undergo surgery initially. So that's that group of women who had to start with chemotherapy. And then if the chemotherapy worked and they were ready to go to surgery and the surgeon could go in and take out all of the disease, they were potentially a candidate for this heated intraperitoneal therapy. And in that subset of patients, it did actually result in improved survival. So that's made a lot of people think about using this therapy in that subset of patients who undergo chemotherapy and then surgery. So again, I bring that up because you might hear about HIPEC therapy. Okay. And we're getting to the end of the talk here. I briefly wanted to talk to you guys about targeted therapy. You may have heard this term. So when we talk about chemotherapy, those two drugs that we talked about, those are medicines that will prevent the cells from duplicating their DNA and dividing. Okay, so sort of generic medicine kills lots of different cells. When we talk about targeted therapy in the cancer world, these medicines have specific targets. Okay, so again, this depiction is a little bit busy, but if you look at the ovarian cancer cell, there's lots of different things going on in the cell that we think can promote cancer cell growth. So we have particular targets, medicines that target a specific protein or a certain receptor, for example. And we have found that we can also target things outside the tumor cell. So for example, this is a depiction of an endothelial cell, which is a cell that lines a blood vessel, for example. And these cells make a very important protein called VEGF, which is depicted here in these little purple circles. And we have a medicine called bevacizumab, for example, that can sop up some of that extra protein so that protein can't go and stimulate blood vessel growth, for example. So again, learning more and more about specific pathways or the ways that these cancer cells can grow have led us to figure out some new treatments. And so this bottom picture also depicts something that we're going to talk about as well, really sort of taking advantage of what we know about how ovarian cancer spreads and how it grows to use a targeted therapy for that. So briefly, just wanted to talk to you guys about bevacizumab. So the name brand of this medicine is known as Avastin. There are a lot of generic forms of that medicine that are available now. And this picture depicts an ovarian cancer cell. And the way that it works is ovarian cancer cells make VEGF, which is this protein that promotes blood vessel growth. And this little blue antibody with the magenta ends is a picture of the medicine. And what it does is it binds up those proteins so that it can't stimulate blood growth. And if the ovarian cancer loses its blood supply, for example, then maybe it's more susceptible to getting killed by the treatment. And so you can see here in 2014, this medicine was approved for people who weren't responding to carboplatin anymore. And then in 2016 for patients whose cancer had come back and we were using it with carboplatin. And then in 2018, the medicine got approved in newly diagnosed patients with ovarian cancer as part of a maintenance regimen after their initial chemotherapy. So again, a lot of information, and we've been using this drug for quite some time in ovarian cancer. And now the last few slides have to do with the newer therapy in ovarian cancer known as PARP inhibitor therapy. Again, many of you may have heard of that as well. This goes back to that slide that I told you was very busy and that I was going to bring back at some point. If you guys remember when we talked about hereditary ovarian cancer, and I talked about the fact that 15% of those cancers are due to a germline or a genetic mutation. But now we're actually looking at patients' tumors as well. And we have found that another 10% of ovarian cancer patients actually have a mutation in the tumor. So they don't have a genetic mutation when they have genetic testing, but when we go and test their tumor, we find a mutation. But if you remember from that slide, there were lots of different things other than just BRCA1 and BRCA2. And so there are lots of other mutations in the tumor that can lead to this problem with DNA repair. And so that's another 25%. So if we look at ovarian cancer as a whole, 50% or half of them may have some sort of problem with DNA repair from all of these other mechanisms. And so patients whose tumors have an issue with DNA repair, also known as homologous recombination deficiency, may be a candidate for some of these newer therapies. Okay. And so this is a picture of a protein called PARP, and it's really important to repair DNA. So if the cell is going to divide and make a duplicate copy, that DNA has to duplicate itself. And in that process of hundreds of thousands of base pairs, there's a potential for an error. So your body, the cells have these proteins that go and repair those mistakes. I always tell patients it's kind of like a spell checker, and PARP is one of these proteins. So you can see here, if your DNA has a mistake and you have PARP protein functioning, it should be able to repair that mistake and the DNA is fine and the cell can divide, right? So we have this class of medicines that will inhibit PARP, so will make this protein not work well. And what happens if those cells, if the PARP can't repair the cells, then you run into troubles with DNA repair and breaks in the DNA. And so if your cell otherwise is fine and you don't have any other problems, it can repair the DNA. But again, in 50% of those ovarian cancer cells, you can have a problem with that DNA repair. So if your cell can't repair itself, either because you've inhibited PARP or it's got an innate problem, then the cancer cell can die. And so that's one of the principles that we use to determine who might be a candidate for this therapy. So just briefly, there are 3 PARP inhibitors that are approved for ovarian cancer. And historically, we were using them in the recurrence treatment. But now we've got some newer data to look at PARP inhibitors for women who've been newly diagnosed. Most of these studies have been looked at in patients who have BRCA mutated cancers. Again, and most of these are oral therapies. And there are some side effects to these medications that warrant detailed discussion. And many patients are on these PARP inhibitor therapies for 1 to 2 to 3 years, depending on where they are in their ovarian cancer treatment. Okay, and the last few slides just particularly talk about a few of these drugs. So for example, olaparib is one that originally got approved in 2014 for women who had recurrent cancer, and in 2017 for women who had a first recurrence of cancer, for example, and in 2018 is actually approved in the upfront treatment, so women who are newly diagnosed with ovarian cancer. So again, you can see the progression of how we study these drugs and how they get approval. So first in the metastatic recurrent setting, and then we move them earlier and earlier and try to see if we can improve in the newly diagnosed patient population. So niraparib is another drug originally approved in 2017 for recurrence, and then in 2020, so just recently, for newly diagnosed ovarian cancer patients. And then lastly, rucaparib, again, approved in 2016 for patients who have recurrence, and then in 2018 for platinum-sensitive recurrent disease. And then veliparib is another PARP inhibitor. It's not yet approved in ovarian cancer, but it was a little bit unique in the sense that this was studied with chemotherapy and then after chemotherapy, and actually showed that the women who received the drug during chemotherapy and after chemotherapy did have a benefit. Again, so the company is looking at seeing if they can get this drug approved in the ovarian cancer population. And then lastly, there's a potential combination in maintenance therapy. So if you guys remember the slide where I talked about the targeted therapy with bevacizumab, there was a study looking at combining that medication with olaparib, which is one of these oral PARP inhibitor agents, in women who had advanced disease. And this study led to the approval of this combination after chemotherapy. So just under 2 years ago. So it's for women who were newly diagnosed and actually had a BRCA mutation, either genetic or tumor mutation of BRCA. So again, building on that backbone of chemotherapy to find additional therapies so that we can keep our ovarian cancer patients in remission. All right. And lastly, I'd be remiss if I didn't mention a clinical trial. Again, a big passion of mine. So when you go to visit your oncologist and you talk about new treatment, you should always ask if you're eligible for a clinical trial. And I do like this video from the National Cancer Institute about clinical trials and why you should consider joining a clinical trial. And I think that's it. So I'm going to stop screen sharing and we'll go to questions.
Thank you so much. That was a really great overview. And we have time for questions with it, which is great. So let's begin the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. So I think with your last slide, a really good starting point is, when should patients consider joining clinical trials?
That's a great question. I really appreciate that. I think clinical trials, historically nationwide have a bad reputation. So a lot of patients, when I bring it up, will say, oh, well, I'm not to that point where I need something experimental at this point in time. And those are for people who, don't have any options left. And that actually is not true. So clinical trials, there are various stages of clinical trials. Some are looking at, very new drugs that have never been tested in humans before. And other trials are looking at new combinations. And so I think one of the things that patients fear is that I'm going to get a placebo or I'm not going to get, good treatment. And that's actually a very common misconception. It would be unethical for me as a cancer doctor not to provide you with the best treatment. So usually these clinical trials offer the standard treatment and then something potentially extra that we could look at. So all that last information that I showed you guys about the targeted therapy and the PARP inhibitors, those were clinical trials that, we participated here at Huntsman and my patients entered. And those are the women who they potentially got the experimental therapy like a PARP inhibitor. And that's why we know that those medications work in not only recurrent, but upfront ovarian cancer. So again, there could be a clinical trial available for you at any stage, right? And it's really important to ask, your doctor, because a lot of times oncologists are busy and they don't sort of think about that, even though we all should. And so you just want to make sure if there's a clinical trial option available for you. So let's say, for example, your cancer comes back. There may be a different trial looking at chemo in combination with something else, or one of these newer therapies compared to chemotherapy. So again, important to talk to your doctor and go through the best options for you. And that may be a clinical trial. So good to consider at any point in your care.
Great, thank you for that. And the next question is about whether maintenance treatments, I think they're specifically referring to PARP inhibitors, just delay recurrence or actually decrease incidence of any future recurrence, or is it too soon to tell?
Yeah, that is a really great question. So in the cancer world, we look at several things to see if one of these new treatments are working. So if you have recurrent cancer and you have something to measure, we want to know what's the response rate. So what's the chance that this cancer is going to shrink? And so that's how a lot of drugs get studied, and we know they're active in ovarian cancer. So that's what, for example, PARP inhibitors, that's how we studied them in women who had recurrent tumors, and we could follow and see the shrinkage, right? So response rate, that's the first step. We want to make sure the tumor responds. And then if we look at a patient population, let's say first recurrence, and you've had chemotherapy and all your disease is gone, we don't really have anything to measure to see if the treatment works. So what we have to look at is how long does it take for a recurrence? Do we delay that recurrence? And then do we improve the overall survival? So in the cancer world, when we talk about recurrence, you know, the longer we can delay a recurrence, we think that's important. That's important for quality of life, for your emotional and mental well-being. So if we can delay a recurrence, that's important. But if we could, you know, keep you cancer-free longer, that's actually even more important. So, so most of the PARP inhibitor studies, all the ones that we've talked about, have showed improved time, so more time before a recurrence happens. And some of them actually, the patients are still being followed because they haven't recurred. So again, there's a subset of patients who do have a long-term benefit, and we, you know, it's the word I love to say is maybe they're cured from their ovarian cancer. So we see both. So we definitely see delays in recurrences, so more treatment, more time in remission, and then there's a population that we think we can potentially cure with these medicines, even maybe the second time around with recurrence. So it's very exciting.
Great, thank you. And I think this is a really good question. This person's asking about whether the outcomes for patients with significant comorbidities are different than those without. So all other things being equal.
Yes, and that's also a very intuitive question as well, because a lot of times, if any of you have participated in a clinical trial, there's a whole checklist about, you know, how healthy you have to be sometimes to qualify for a clinical trial. And so again, we want to be very careful with people who have comorbidities. And so I would say as a whole, it really depends on the degree of control of your concurrent condition. So let's say poorly controlled diabetes as an example, right? So my goal as an oncologist is to work with your primary care doctor or your diabetes specialist to get that diabetes under better control, because number one, that's just good for your general health. And number two, it will actually make giving you the chemotherapy or treatment for your ovarian cancer easier, because there's a lot of overlapping, you know, side effects. So diabetics can have neuropathy, chemo can cause neuropathy. So we want to maximize your side effect control as much as we can. So getting those chronic illnesses under better control will help us. But, you know, we treat a lot of patients with comorbidities. I would say ovarian cancer tends to be a cancer of older women. And so many of them do have high blood pressure, diabetes, heart disease, for example. So it's very important to make sure your oncologist knows all of your medical issues and that they work with your specialist in controlling all of those and watching things very closely. I mean, we work in very close contact with a lot of cardiologists, for example, to make sure we have the heart rhythms controlled, the blood pressure controlled during chemotherapy. So it's a team approach. Again, we just having a chronic comorbidity would not exclude you from chemotherapy. It's just having your doctor work closely to keep those as best managed as possible.
Great, thank you. And this person is asking if there's any relationship between endometriosis and ovarian cancer.
Yeah, good question. So if you guys remember back to that slide where I talked about the different types of the different histologies, and specifically I talked about serous and that being 75%, there were a few other ones on the list. Endometrioid type, which sounds very much like endometriosis. And there's another type called clear cell, for example. So just as a background, so endometriosis, for those of you that don't know, the tissue that is the inner lining of your uterus. So that's the tissue that builds up and sheds when you have a menstrual cycle. That tissue, we can find it in other places within the pelvis. And like during a cycle, that tissue can grow and it can cause women pain and discomfort. For example, it can cause issues with fertility. And so that's the same tissue that's in the uterus, and that tissue is potentially prone to turn into cancer as well. So there's a class of cancers called endometriosis associated ovarian cancer. So there is an association between endometriosis and ovarian cancer. It's typically the endometrioid types or the clear cell types. Okay. And so a lot of the treatment is the same. But again, yes, having endometriosis, those areas could turn into ovarian cancer.
Okay, great. Thank you for that. This person is wondering if tubal ligation
Mhm.
is a preventative measure regarding ovarian cancer.
Yeah, so that's a great question. So women have always asked, like, if I have my tubes tied, is that, a good way to prevent ovarian cancer? And it is actually. Women who have had their tubes tied tend to have less ovarian cancer than women who have not. So the answer to that question is yes. And the nobody really knows why exactly. And but that has been shown that perhaps if you guys think about from the vagina to the cervix to the uterus, it's connected to the fallopian tubes. So if you cut off that connection, then perhaps the ovaries don't get stimulated, or you can't develop, cancer cells within that channel. So nobody really knows, but the answer to the question is yes.
Okay. And so I'm going to go back to PARP inhibitors because someone is asking, and I think this is a good question because there's a lot of confusion about this. Are PARP inhibitors recommended for patients who are non-BRCA and non-HRD?
Oh my gosh, that is the $1 million question. So that's it's a great question. So we know, and if you guys think back to those horribly busy complex slides that I showed you, so if your DNA has the homologous recombination, it's really just more exquisitely sensitive to PARP inhibition, right? So that doesn't mean that people who don't have it don't benefit. So that's actually been looked at in one of the studies that I showed at the end. So for example, niraparib is one of those medicines, and the women who were non-BRCA or non-HRD still had a benefit to PARP inhibitor therapy. Not as much, so maybe not as long of a time in remission, for example, and but it is FDA approved in that indication as well, right? So that's the tricky population where I really have a sit down with those patients and talk about the numbers of what's the benefit to you, particularly if you're non-BRCA, non-HRD, and versus what the side effects of those medicines are, right? So if it was a medicine that didn't have any side effects at all, then probably everybody would want to take it. But there are some potential side effects that really have to be discussed one-on-one with your oncologist to see if that benefit outweighs the risk for you individually.
Okay, great. And so this person is saying that they have Lynch syndrome, and they're wondering if there's anything a person can do to turn on the working gene and turn off the non-working gene.
Yeah, so that's a great question. And it is relevant to ovarian cancer too, in the sense that a lot of the medicines that we've talked about in cancer cells, for example, they tend to activate things, right? So there's too much of this protein, for example. So we're really good at making drugs that inhibit or block things that are too active. So I always think of it as the accelerator is on and I've got to put the brake on. So a lot of these medicines work that way. But having something be missing and trying to turn it on or replace it is much, much harder, right? So if you think about it's gene therapy, it's basically like, can we restore that non-working thing? So it's harder to give back something that's not working versus shutting down something that's working too much. And so that's the issue with Lynch syndrome. So we watch our Lynch syndrome families very, very closely. And we know which cancers they're at increased risk for. And so they get a lot of screening and we do a lot of prevention with those patients as well. So again, a great question. And that's really where the field is going because there's a very important protein called P53, which is usually mutated in all high-grade serous ovarian cancers. And we've got to figure out how to give that protein or give that gene back to the patients to help prevent the cancer. So again, a very active field of research. Great question.
Great. And I'm just wondering if you can briefly discuss primary peritoneal cancer.
Yes, absolutely. That's a great question. So if you guys remember from that picture of the ovary that I showed, and I showed the epithelium or the lining of the ovary, So those cells, they're very, very similar to the cells that line the peritoneum or the abdomen. So if you think about your abdomen, on the inside, there's a lining called the peritoneum, and those cells are the same, right? And so they can turn into ovarian cancer, except we don't call it ovarian cancer because it didn't start in the ovary. So we call that primary peritoneal cancer. So patients who, let's say, for example, they had bleeding and they wanted to have their uterus out and got their ovaries out at the same time, and then, quote, they got ovary cancer. You're like, how does that happen? And generally speaking, it's probably primary peritoneal cancer. So it's really, it's down to semantics. Where did we think that cancer started? Because we have women who look like they have ovarian cancer, but their ovaries don't have any cancer. So where did it come from? And it's likely from the peritoneum. So again, a lot of people will interchange the terms because it's treated the same, staged the same, etc. But it's where that cancer starts. So if you want to be correct and you don't have tumor in the ovary, you should say primary peritoneal, or it could start in the fallopian tube, for example. So great question.
Okay, great. And I think we probably only have time for one more question. And so I'm going to ask a question about recurrence, because ovarian cancer is highly recurrent. So what should patients be on the lookout for with recurrence, like in terms of symptoms, and how are they monitored to see if they might be having?
Yeah, that's an excellent question. So, patients are so happy when they finish chemotherapy, or if we do maintenance therapy. But, as an oncologist, the follow-up and the surveillance is really important. So I tell patients when we meet, I hope to know them forever until I retire, because I'm going to always be keeping an eye on them, right? And so after upfront therapy is over, the typical surveillance or follow-up plan I generally will see my patients every 3 months. For the first 2 years. So we kind of count the clock from the end of surgery. And I know the surgeons count the clock from surgery, but we count from the end of chemotherapy. So I'll see my patients every 3 months, and we'll do a myriad of things. So blood tests, for example, pelvic exam is very important. And in those blood tests, we may be measuring a tumor marker called CA-125, which many of you may know. So this is a protein that tends to be made in abundance by ovarian cancer cells. And so if it's high, we can follow that number again. And then sometimes we will do CAT scans depending on the particular patient. So CAT scans are not, you don't have to do CAT scans on a regular interval. I always will say I will do them based on symptoms, based on a CA-125, or if I find an abnormality on exam. So every 3 months for the first 2 years. And then we get to space that out to every 6 months for years 3, 4, and 5. And then after years 5, I see them once a year. And the important warning signs are, I always tell my patients, like, your body better than anyone else, right? So if there is something that's new and persistent, that's when I need to hear about it. So, I had one episode of nausea and it went away, and maybe I had bad food, whatever. But if you're like, I have this nausea and it's there kind of every day now, and it's not really going away, you don't wait for your 3-month follow-up appointment to call me and tell me that, because I will see them immediately, do blood work, maybe do CAT scans at that point, right? And so we want to try to catch these recurrences earlier. Maybe patients could have another surgery, for example. But again, I always tell patients, your body the best. And if there's anything that you think is wrong, just call your oncologist, talk through it, and decide if you need to come in and get seen earlier or have CAT scans. And so again, keeping those follow-up appointments with your care group, whether it's your gynec surgeon or your medical oncologist, that's actually really important. Great question.
Great. And I think that's a good place to end this webinar. So thank you so much, Dr. Werner, for being here, for the great presentation, and for answering all of these questions. And thank you to everyone who participated in today's webinar and submitted their questions. We ask that you please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and there will also be a link that's sent to you in a follow-up email. So please fill that out. We look at your feedback and use that to inform our programming. And all of the surveys are anonymous. So thank you again, Dr. Werner.
Yeah, no, it's my pleasure. And I just want to say thank you to everyone who listened, and hopefully you just got a little bit more understanding about ovarian cancer. And thank you for being the brave patients that you are. And it's my pleasure every day to get to meet new people and share what I know about ovarian cancer and help fight the fight. So thank you all.
Great, thanks.